So this was, the forced choice exercise is something that we've used a lot over the years, and it was developed here, and it's a really useful example of how people look at things differently. And we developed this just in-house to use with osteopaths to find something a bit more musculoskeletal, so to do with the sorts of things that osteopaths might come across in their day-to-day practice as an example. And I just thought it might be helpful to sort of translate those different ways of looking at things into a more clinical based example. It's still made up. When I talk about experimental surgery, I don't know, I mean, I'm an osteopath, actually, although I'm a policy manager at the GOsC, I'm actually an osteopath, but it's still kind of hypothetical and made up, but maybe a bit more musculoskeletal in its focus. So this is a patient who suffered a knee injury. The injury is resolved, but they're left with pain and discomfort on a daily basis. And there are 4 treatment options that they're offered. So standard surgery, 85% chance of reducing pain, but they may have some reduced mobility. Experimental surgery, where there's a procedure which has a 50% chance of completely resolving the issue, leading to full function and no pain, but also a 25% chance of not improving things at all, or a 25% chance of actually making things worse. Conservative treatment, so manual therapy, physio, osteopathy, rehab exercises, use of medication, but things are likely to deteriorate over time. And do nothing, just carry on with the pain and discomfort. So they were the sort of 4 choices. And we were thinking about, you know, what might inform those different options. I don't think we've got a Mentimeter slide on this one, have we, Fiona, on the options? But you may have your own thoughts about, in those circumstances, what you might go for. I had hip surgery at the beginning of last year. I had a hip replacement, and what was important to me, and the surgeon was very good at the time in giving me information and options and supporting whatever decision making I was going to come to around that. I wanted to reduce pain. I'm quite active, so I wanted to preserve that activity. It was in the middle of the COVID pandemic, so that was in my mind as well, about whether it was all right to go into a hospital and have something done in those circumstances. And I felt I was quite young to have a hip replacement as well, and the psychological effects of, am I old enough for this kind of stuff? But taking all that stuff into account, ultimately, and it took about 2 or 3 months of thinking and decision making and seeing the surgeon a couple of times and kind of really getting my head around it, I came to the decision to have surgery. But it was important to have that kind of process. I wouldn't have wanted to have seen someone and had to make a decision on the spot as to what I was going to do. It was a gradual process of kind of exploration and thinking and all those kind of things, really. In these circumstances, between those kind of choices, again, we looked at that context of values-based practice earlier, and that framework. And at the time, and I remember when we saw that framework developed, and I was on the other side of the fence then, I was working in osteopathic education rather than at the regulator. And I thought, well, context is always going to apply, but it didn't really strike me about how much that context would apply, about sort of age and circumstances, and you know, what was important to me at that particular moment. So all of those issues kind of combined in my own decision making, and I think will be the the same for everyone, really. I would probably not go for experimental surgery. I'm not particularly a risk taker. I wouldn't have taken the treatment 1 option in the past exercise that we just did, really, because I'm quite risk averse. So I would probably go for standard surgery, but perhaps via a route of conservative treatment for a bit to see how that worked. That was my approach, really. But we are all different, and as practitioners, we can't impose our own kind of thoughts onto the patient. If a patient is reluctant to go down a particular route, then it's not for us to tut and say, well, why not? Just get it done. It's not their decision, it's our decision. And in a sense, that kind of shared decision is really about the patient. It's the patient's informed decision, rather than you may come to a plan together, but it's about what the patient wants and decides. And I think that was largely it.